Hello everyone. So in today's video, we'll be learning about diabetes mellitus. All right. So let's start with the definition of your diabetes mellitus. Yeah. So this is a heterogeneous metabolic disorder. All right, which is characterized by chronic hyperglycemia. Yeah, and disturbance in the metabolism of your carbs, fats, and proteins. All right. Now let's come to the classification of your diabetes mellitus. All right. Diabetes mellitus is classified based on its etiology. All right. So based on its etiology, diabetes mellitus is classified into two types. There's your type 1 and then there's your type 2. All right. Your type 1 has a juvenile onset. All right. Whereas your type 2 has a maturity onset. Type 1 is insulin dependent. All right. Whereas your type 2 is non-insulin dependent. All right. Your type 1 constitutes of about 10% of the cases, whereas type 2 constitutes about 80% of the cases. All right. And coming to your type 1, it has two subtypes. Yeah. There's your type 1A and your 1B. So 1A is an immune mediated condition. All right. So what happens here is there is your autoimmune destruction of the beta cells of your pancreas. All right, which leads to insulin deficiency. All right. Whereas your 1B is idiopathic. That means the cause for this is not known and it's been tested negative for your autoimmune markers. All right. The clinical features for your type 1 are insulin deficiency, all right, and a tendency to develop ketosis. All right. Now let's come to your type 2. All right. Type 2 affects older individuals. All right. And also young obese individuals. All right. Now let's come to the risk factors for your type 2. Right. There's your obesity. Then there's your hypertension, familial history of diabetes mellitus, an individual's race, ethnicity, all right, and lastly, impaired glucose tolerance. All right. With that done, we're going to come into the pathogenesis of your diabetes mellitus. All right. Before starting the pathogenesis of type 1 and type 2 diabetes mellitus, let's see how does hyperglycemia occur, like what leads to hyperglycemia. All right. So the following conditions lead to hyperglycemia. 1, decrease in insulin secretion. Yeah, if there's decrease in insulin secretion, there's increase in your blood glucose level. All right. Then your decrease in glucose used by the body. All right. And lastly, increase in your glucose production by the body. All right. So these three conditions lead to hyperglycemia. All right. Now let's come to the pathogenesis of your type 1 DM. All right. So there's usually a genetic susceptibility. All right. Susceptible gene on your HLA region in chromosome 6 and concordance in identical twins. All right. Along with some environmental factors such as any viral infections, seasonal or geographical variations, all right, or any bovine proteins, and your chemicals. All right. So your genetic susceptibility along with some environmental factors leads to some autoimmune factors. All right. Now, which could be islet cells antibodies, all right, or your insulitis, or CD8 plus T cell mediated destruction of the beta cells of pancreas. All right. And all of these three conditions which lead to your type 1 DM. All right. So that was about your type 1 diabetes mellitus. Now let's come to the pathogenesis of your type 2 diabetes mellitus. All right. Again, certain genetic factors, all right, such as concordance in your identical twins, which has an about 80%, all right, and both parents being diabetic, this contributes about 50% risk. All right. Now these genetic factors lead to a decrease in your insulin secretion. All right. Now this decrease in insulin secretion, all right, is because of these genetic factors. Now there can also be some constitutional factors, right, such as your obesity, your hypertension, and decrease in physical activity. All right, which leads to insulin resistance. All right. Now this insulin resistance can be a receptor defect or post receptor defect. All right. Now all of these conditions lead to increase in your hepatic glucose synthesis. All right, which leads to your increase in blood glucose level, that is your hyperglycemia. All right, leading to type 2 diabetes mellitus. All right, so that was the pathogenesis of it. All right, so now let's come to the complications of your diabetes mellitus. All right, your diabetes mellitus has two complications. The first being your acute metabolic complications, and the second being your late systemic complications. All right, let's start with the pathogenesis of your acute metabolic complications. All right, so what happens initially is that there is insulin deficiency. All right, and this we know leads to your hypoglycemia. Yeah, that is your increase in blood glucose levels. So hypoglycemia leads to fatigue. All right, that is weakness. And then there's your glycosuria. All right, that is glucose in the blood. Now glycosuria usually leads to your vulvitis. All right, and this leads to two conditions. One is your increase in your catabolism and decrease in your anabolism. All right, let's discuss your increase in catabolism first. Increase in catabolism leads to increase in lipolysis. All right, which leads to increase in your free fatty acids and oxidation. All right, which leads to your ketoacidosis. All right, there are a few additional points here, like increase in catabolism leads to polyphagia and weight loss. All right, and increase in lipolysis leads to your muscle wasting. All right, so this was the first thing we were concerned with, ketoacidosis. Now coming to decrease in your anabolism, this leads to your osmotic diuresis. All right, which leads to your dehydration, and along with dehydration there's also loss of electrolytes. All right, and this eventually leads to your diabetic coma. Now here osmotic diuresis leads to your polyuria. All right, and dehydration and loss of electrolyte lead to two things, that is your hypotension and tachycardia. All right, so we got two things here. One was ketoacidosis and the second was your diabetic coma. So this is what happens in acute metabolic complications. The individual develops your diabetic ketoacidosis and hyperosmolar, all right, hyperglycemic non-ketotic coma. All right, so these were the things that we were seeing in your acute metabolic complications. Now there is some interesting concept here, that is your Somo-Guy's effect. All right, let's understand what is this Somo-Guy's effect. So what happens here is, in an individual, all right, having your DM, a hyperglycemic condition, hypoglycemic, all right, hypoglycemic episodes, all right, hypoglycemic episodes may develop in your type 1 DM. All right, now I know you might be thinking, how can a hypoglycemic condition, all right, develop in a hyperglycemic individual? So this happens because of, one, there is increase in your insulin admission. All right, a very high dose of insulin would have been given to the patient. Second, the patient would have missed his meal. All right, and third, stress. All right, so and this leads to your So this hypoglycemic episode may lead to one, brain damage, all right, and second, rebound hyperglycemia, all right, which is known as your Somo Guy's effect. All right, I hope you got that clear. Now that we're done with your acute metabolic complications, let's come to the pathogenesis of your late systemic complications. So in this, many of your systems are involved, and it is a late complication. It occurs over course of many years. So what happens in this is that we start with your three systems. All right, first is your vascular system, all right, and then we'll go to metabolic, and lastly the immune system. All right, coming to vascular, we'll be starting this under two headings, one being your macrovascular and second your microvascular. All right, so under macrovascular we will study your atherosclerosis, all right, infarction of your heart, brain and your bowel, all right, also gangrenes in your extremities, all right. Now let's come to the microvascular. So what happens in this is that the individual may develop micro angiopathies, all right, such as your neuropathy, nephropathy, and your retinopathy. All right, now these were the vascular complications. Now let's come to the metabolic complications. These will be starting under two headings, all right. One is your sorbitol pathway. You might remember this from your first year biochemistry, and the other is your protein glycosylation, all right. Under the sorbitol pathway, we're going to discuss the lesions, all right. The lesions may develop in your aorta. Second is your eye, specifically your lens. So in this, what happens is that the individual may develop cataract, all right. And third are your kidney nerves, all right. Now coming to protein glycosylation, we'll study your bone marrow thickening, all right, yes. And under the immune heading, what happens in the immune system, we'll be starting this under two headings again, all right. One is defect in your cell mediated immunity and defect in your PMN, all right. So defect in your cell mediated immunity leads to conditions such as your tuberculosis, urinary tract infections and your pneumonia, all right. Whereas defect in your PMN leads to two infections specifically, that is your fungal and bacterial, all right. Let's draw a diagram to summarize the late systemic complications an individuals face, all right. Please bear with me, I'm not a good artist. All right, so we saw in the eye, one we saw here. Where did we see that? Yes, your retinopathy, all right, which was under the microangiopathy heading, that is of your microvessels, all right. That was your retinopathy. And the second thing we saw related to eye, where the under the metabolic heading sorbitol pathway, we saw lesions of the eye, all right. That was a cataract, all right. Now let's come to the heart, all right. Let's see what did we see in the heart. We saw infarcts, all right. So coronary atherosclerosis, all right, and your ischemic heart disease. All right. Then we saw your bowel. All right. Again, what did we see there? There we saw your infarct of your bowel, and we also saw autonomic dysfunction. All right. Now let's come to your kidneys. All right. On the kidneys, what did we see? We saw two things. All right. One, we saw your diabetic nephropathy. Right. We saw your diabetic nephropathy under the heading your microangiopathies of your microvascular, and we also saw urinary tract infection. All right. All right. Now let's come to the extremities. All right. What did we see in the extremities? We saw gangrene in the extremities. We also saw your diabetic neuropathy. Yes. Right. So what do we see here? We see diabetic neuropathy. All right. Now, gangrenes. Where did we see gangrenes? We saw here. All right. Gangrene in the extremities. All right. So this was a diagram to summarize all the late systemic complications. All right. All right. Now that we're done with the complications, let's come to the diagnosis of your DM. All right. So what is the criteria for your diagnosis of your diabetes mellitus? All right. So first, the random blood sugar should be more than 200 mg per deciliter along with the symptoms. All right. Second, the fasting blood sugar should be above 126 mg per deciliter on more than 2 occasions. All right. And the third one, oral glucose tolerance test, should be more than 140 mg per deciliter after 2 hours. All right. Now, oral glucose tolerance test. What is this? All right. Let's look at the indications for this. What are the indications for your oral glucose tolerance test? 1. The patient has glycosuria but no diabetes mellitus. All right. Second, patient no DM symptoms. All right. Second, patient has DM symptoms but no glycosuria. All right. Third, patient has a family history of diabetes mellitus. All right. Fourth, a woman having large babies. All right. And last, patient with either your nephropathy or neuropathy. All right. So these were the indications for your oral glucose tolerance test. Now, the last topic we'll be discussing is your glycosylated HB, that is your glycosylated hemoglobin. All right. Also known as your HbA1c. All right. So first we'll discuss the normal value. What is the normal value? 3.5% to 6% of your total hemoglobin. All right. Now, 2. What is this glycosylated HB? So your glycosylation of your hemoglobin is a slow, non-enzymatic and very important irreversible process. All right. Third, the amount of glycosylated hemoglobin which is found in your RBC depends on level of glucose in your plasma. All right. So the amount of the glycosylated hemoglobin which is found in your RBC depends upon the level of glucose in the plasma. All right. Fourth, HB1AC, that is your glycosylated hemoglobin, remains in blood, all right, for 120 days. All right, that is still the RBC is in the blood for those many days. Your glycosylated hemoglobin will be there in your blood for 120 days. All right, till your RBCs are destroyed in your spleen. Fifth point, so based on this, your HB1AC is a good indication, all right, of how well the glucose level has been controlled in the body since the past 120 days, that is roughly 4 months. All right. So with that, we conclude today's video. A quick recap of what all we did today. All right. So we studied your diabetes mellitus. All right. We went through its definition. We did the etiological classification. There were two types. There was type 1 and type 2. Type 1 having a juvenile onset, type 2 a maturity onset. All right. Under type 1, we studied that there were two subtypes. There was 1A and there was 1B. And then we went on to the pathogenesis, where we saw hyperglycemia may result from three conditions. That is your decrease in insulin, decrease in glucose used by the body, and increase in glucose production by the body. All right. We saw the pathogenesis of your type 1 DM. We saw the pathogenesis of your type 2 DM. And then we went on to study the complications. We saw two complications, the acute metabolic and the late systemic complications. And after that, we also read about Somo-Guy's effect. All right. After the complications, we went to the criteria for diagnosing your DM. There were three criteria. All right. And the last topic that we did was your glycosylated HB. All right. So with that, we'll conclude today's class. Thank you for watching.